So this second module, the topic is all about like understanding cancer diagnosis and all the kind of monitoring that goes along with this thoroughly unpleasant journey. So I'm going to talk a little bit about cancer staging, cancer grading, blood tests, the various kind of scans, and then some of the advanced testing that is just becoming available, or that's been available for a while but is just becoming maybe affordable, or has been available for a while, isn't particularly affordable, but is just becoming kind of more reliable. So cancer staging and cancer grading. So these are kind of often confused. Cancer staging, we usually think of 4 stages, often subdivided. Different cancers have different types of staging, especially different substages. And cancer staging is really about where the cancer has got to. Unfortunately, cancer spreads and grows in other places of the body. And this is kind of a unique point of cancer, right? Bits of your body can't move to other bits of your body and start growing, right? There are mechanisms to stop that happening. When cells are floating around in your blood, they can't just stop and stick somewhere. There are mechanisms to kill them, there are mechanisms to stop them sticking onto places, but cancer is able to subvert and get around a lot of this. So the staging depends on the point of origin of the cancer. I am most familiar with colorectal cancer because that's the cancer that I have. I think the staging for colorectal cancer is relatively simple, but other cancers, it follows the same kind of pattern. So stage 1 is where there's like a tumor or tumors in one place, and particularly with hard tumors, they're going to be thinking of like in an organ. And stage 2, it's kind of maybe spreading within the organ, or maybe just getting to the edge of the organ, kind of coming through. So you can think, you know, with cancer in the intestine, it's like trying to get out of the wall of the intestine. Then stage 3, it's kind of spread locally. Often it's going to be spreading to lymph nodes. And stage 4 kind of spread to distant organs. And depending on the type of cancer, usually, yeah, stages 1, 2, and 3, there's at least some chance of a cure. And traditionally, we've thought of stage 4 as being incurable. But there are some very kind of strong exceptions to that. So colorectal cancer that's just spread to maybe a couple of lymph nodes some distance away, or that's just spread to the liver. Some of those patients are able to be treated with curative intent, right? Liver surgery and remove the primary tumor, follow up with some chemotherapy, and hopefully at some point in the future say that the cancer hasn't come back and it's been long enough that the patient can be considered cured, whatever cured means, right? In most contexts, I guess we'd say someone's cured if their chance of having cancer again is just the same as someone who wasn't diagnosed with cancer. I think that's like a practical definition of cure that many of us are looking for, right? So where our oncologist says there's been no evidence of cancer for a certain number of years and your chance of it recurring is as low as the general population. So there's staging, and then there's also grading. Grading is really, what does the cancer look like under a microscope? So this is like in a pathology report. So maybe a biopsy has been taken, or maybe a tumor has been removed and sliced up, and examined under a microscope. And its grading is really about how different do the cells look compared to normal healthy cells. So there's a grade X, which means they couldn't do the grading, and then grades 1 to 4, where they look like healthy normal cells, and yeah, 4 you'd say sort of they look very mutated. And it seems to be that, yeah, as the grade goes higher, the kind of cancer is disclosed more aggressive, so more chance of spreading, more chance of becoming stage 4. Now, cancer grading and cancer staging is useful for teaching how cancer works. It's useful for, I guess, making economic decisions about how like how a government should spend money on healthcare, and what drugs should be approved and what drugs should not be approved. In my 6 years of dealing with cancer and talking to hundreds and hundreds and hundreds of cancer patients around the world, I found no benefit at all in talking about cancer staging and cancer grading. None whatsoever. It seems kind of completely irrelevant to patients. In theory, grading kind of, and is to do with prognosis, as is staging really, but I haven't seen any use in it from a patient's point of view at all in 6 years of talking to really a huge number of patients around the world in various cancer Facebook groups that I'm in. So as I said, like the grading comes from the pathology report, and you need to like physically cut up tissue and stick it under a microscope, and that's called histology. So it might say like histology report or pathology report. And I guess the kind of relevant bit for us about that is that you basically need to take out cancer, to do biopsies or whatever, to be able to say with any kind of degree of certainty what's going on, right? So that's why when the cancer is just found straight away, specialists are quite wary of talking about it in any kind of certain terms. So in my case, for example, primary tumor was found during endoscopy, colonoscopy, and there's a massive tumor in my intestine. As a patient, I'd say, well, it's quite obvious. It's at least stage 3, because if the tumor is that big, cancer would have spread quite, to other places. But of course, the endoscopist was like saying, "Oh well, we have to wait for the biopsy results and then the scans." So typically, as cancer patients, cancer is found in some cases through some kind of screening, or often we're at the hospital for some other reason, maybe some kind of cancer-related symptom. But in the case of colon cancer, for example, 50% of patients present with no symptoms. In my case, it was bad reaction to antibiotics. Fortunately, the doctor was a bit suspicious and sent me in for testing, and it was found before I had a fatal, intestinal obstruction and dropped down dead. So on to kind of blood tests and tumor markers. So typically after the cancer's been, well, let's say someone's had surgery, cancer's been staged, you'll be having ongoing blood testing and ongoing scans. Of course, scans and blood testing can also be a big part of diagnosis, scans in particular. So blood testing is something that, we get, I think, very used to quite quickly. Typically, you're going to be having monthly blood tests for a long time, hopefully, if you stay nice and healthy for a long time. And we're concerned with various aspects of blood testing. So, for example, tumor markers, which are kind of potentially related to the cancer in our bodies. Tumor markers are often called biomarkers, especially in the US. So these are things you can measure that hopefully relate to the amount of cancer, the activity of the cancer, maybe its potential to spread. And it's a very, very, very inexact thing. One of the reasons it's inexact is, of course, typically we wouldn't know our normal tumor marker levels before being diagnosed with cancer. Maybe that's going to change in the future. Maybe, you know, whenever you go for a health check or whatever, they'll measure a whole panel of tumor markers and keep that on record for you. But that doesn't happen at the moment. So that's one reason, is like we don't know the baseline. Tumor markers can be elevated for various reasons. A very common tumor marker, CEA, which is used for a whole range of cancers, that can go up in response to treatment. So, you know, you can get a bit of a shock when you know, let's say you start some chemo and CEA rises, or start radiotherapy and CEA suddenly rises. It's kind of scary. Often with tumor markers, your oncologist will say, don't worry so much about the absolute number, but look for, is it rising or falling over time, that kind of thing. Yeah, as I said, tumor markers are not accurate. They may be a good predictor for some patients. They may be a poor predictor for others. They may work well for you for a while and then not work well for you later, which happened to me. So for colon cancer, we typically measure CEA and CA19-9. For different cancers, there are different tumor markers. Some tumor markers are used for a whole range of cancers. And yeah, CEA seemed to be like a good measure of what was happening, because it, you know, if it was rising for a couple of months, and I had my scan, my 3-monthly full body scan, maybe I would see tumor growth. When CEA was falling, I'd see tumor shrinkage or tumors disappearing. And then at some point, it became at least temporarily useless, because CEA was nice and stable, and then a scan revealed a 75mm tumor covering my liver, which came as quite a surprise. So yeah, trends are important. Having tumor markers that are good indicators for you is obviously really good. So if the tumor markers seem to be a poor indicator, it's really worth pushing the oncologist for what other tumor markers may be available. So there are tumor markers that seem to be useful, but only a bit, and thus aren't standard, but those might be a good option for you. There's more research coming out about tumor markers all the time. So I think that my oncologist for a while was measuring a different tumor marker, I think CA125, which is usually associated with gynecological cancers like ovarian cancer, but for colon cancers, colorectal cancer, it does seem to be useful for cancer that spread to the abdominal membrane as well. So that might be, you know, worth doing if your tumor markers don't seem to be reflecting your situation as seen in scans. You may better, if your oncologist is cooperative, they may be able to order a whole bunch of tumor markers for you. And if they see some that are elevated, then those might be worth monitoring after a while. And new tumor markers are being invented all the time. So it's worth asking about those as well. When we have our blood tests, a whole range of stuff is measured. We will typically have what's called a full blood count in the UK, and some in the US, and it's called complete blood count. And this is looking at the red blood cells, the white blood cells, the platelets. So red blood cells are very important for us because they carry oxygen to cells and they carry carbon dioxide away from cells, which allows us to live. And they're very relevant for us as cancer patients because, unfortunately, some chemotherapies cause a lot of problems with the manufacturing of red blood cells, which happens in your bone marrow. And in some cases, actually, these counts can be used to see if certain kinds of cancer have spread to the bone marrow. And then we also look at the white blood cells, which help fight infection. And of course, and unfortunately, various cancer treatments cause white blood cell suppression or immunosuppression. Chemo tends to reduce the number of white blood cells, and that often gets to a point where you have to have a chemo break, chemo holiday. Just on that point, I have looked a lot for research about chemo breaks, and there doesn't seem to be any good research about how long it's safe to stop chemo for, what the effects of that are on your long-term survival. I just haven't found good data. I've talked to lots of oncologists about it, and it's basically just their feeling of how many cycles of chemo they think it's safer to miss. In some cases, you may be able to switch to a different chemo that doesn't cause bone marrow suppression or whatever, or that causes less white blood cell suppression. In the notes that I'm going to produce for you, in the process of producing for you, I go into like all the various points of the blood tests, like what the different numbers mean and what the different things stand for. But typically with red blood cells, you're measuring like the hemoglobin, which is its ability to carry oxygen. You're measuring like what percentage of their blood is actually red blood cells, because there's loads of water in there and various nutrients and loads of platelets and white blood cells. So it's a whole mixture, but it's useful to know the percentage of red blood cells. Platelets are the things that make blood sticky, and they're very important in wound healing. And for cancer patients, they're very relevant because if platelets are very low, you may not be able to have surgery. This happened to me. I waited months and months and months, hoping for surgery, wishing that the platelet count would creep up. And it seems that my spleen is big, enlarged spleen, probably from liver surgery, maybe kind of scarring inside the liver. It's causing like local hypertension, which could cause an enlarged spleen. And the spleen, one of the jobs is to break down old platelets. If the spleen's too big, it's too enthusiastic, destroys healthy new platelets as well. So platelet count is important. Also, another reason platelet count is very relevant for surgery is that if the platelet count is low and you're doing abdominal surgery, you may be told you can't have an epidural because it's too dangerous. These kind of things are actually not decided by the surgeon. Usually, I think it's the anesthesiologist. Anesthesiologist is like the person that obviously is in charge of your anesthesia, but they're really also in charge of like your vital signs during the surgery and your fitness to have the surgery in the first place. So they make decisions about, can you have an epidural or not? Can you even have the surgery or not? Some surgeons will agree that you can have like a platelet infusion, but some don't, and it depends a lot on the surgery. So in my case, platelet count was just about enough to do the surgery, and it was all fine, hence I'm alive. But the surgeon didn't really want to do platelet infusion because he felt that, yeah, maybe the platelets would just get all destroyed very quickly anyway, and he wasn't sure about the quality of my platelets that can be tested. Yeah, so platelet count, very, very important for us for various reasons. We're also, as cancer patients, very concerned with liver function. This affects your fitness for surgery, for example, but also affects your ability to have chemo, because chemo is broken down in the liver. And in some cases, we're taking drugs that turn into chemo drugs in the liver. Things like Xeloda or TS1, you may have heard of, they get metabolized into chemo drugs in the liver. So liver function is very important, and unfortunately, various cancer treatments cause trouble with our liver. Radiotherapy to the liver causes damage of the liver function. Surgery to the liver obviously reduces liver function for quite a while, but it should return to normal. And chemo reduces liver function. So those liver function parts of the tests, things like gamma GTP, they're really important, and you can read about that in the guide I'm putting together for you. Just looking at my list. So yeah, there's also what's called the chemistry panel, or the metabolic part of the blood test. So that's looking at nutrients in the blood, but also things like the enzymes and the electrolytes. So those things like your potassium level, sodium level, that kind of thing. Some of those are very relevant to whether you can safely have certain drugs or not. And yeah, so as I said, all the details will be in the guide, as some of it's quite technical, but it's worth always keeping copies of all the blood tests. And I've just found it's really worth pushing the specialists and the oncologists as well, just if there are issues, what can be done to fix them? Is it just a case of chemo break? Are there alternatives? I don't enjoy chemo. I did it for 5 years, but it's very important, and I felt very uneasy having chemotherapy breaks. So onto scans. I know that obviously most of us have had all the different types of scans possible, but just very briefly, I will explain like what the scans involve as well, just in case maybe some of you haven't had a PET scan, or you've had maybe CT but not MRI. As patients, we often kind of wonder like what's the best scan to have, but that's not really a relevant question, because the scans have different uses and they're used in different situations. So I'll just go over like the 3 common scans. The CT scan, that is essentially just X-rays. CT stands for computed tomography. Tomography just means a picture made of slices. Essentially, you've got just an X-ray machine that it has a moving table, and you lie down and it takes an X-ray of you and then moves you a little bit, takes another one, moves you a little bit. Does this for 10 to 20 minutes, really, maybe up to like 30 minutes, depending on the scan and the resolution. If they're smaller slices, you're going to get a more accurate picture, but the scan's going to take longer. Often we're going to be doing a CT scan that is called an enhanced CT scan, or a CT scan with contrast. And this is where a contrast agent is put into you by an IV drip, or like not IV drip, sorry, intravenous, like a injection. And that could be done by a nurse, or it could be done by machine. So you might have a nurse will come and place the needle in you and like attach it to what's it, like a drip, but it's got a pneumatic syringe. And that contrast agent, as the name suggests, gives more contrast to the scan. So it spreads throughout your body, and then on the scan, the differences between tissues and things will show up kind of with more contrast. That contrast agent feels very odd. It's like a strange, warm feeling spreading throughout your body. It's not particularly pleasant, particularly the first time you have it. It's a bit of a weird feeling in your mouth as well. Many patients say they feel like they're going to wet themselves or whatever. Yeah, but contrast agent is important because it makes the scan more useful. MRI can also be done with contrast agent, and I'll talk about MRI scans in a second. But one of the key points of the contrast agent, and this goes back to blood testing, is that it can cause kidney damage, which means if you're having kidney issues, you'll often have to do the scan without the contrast agent. I've talked to various radiographers and oncologists and stuff about this damage, and I've read some papers on it. As far as I could see, I'm not a doctor, but the chance of it causing damage if you got completely normal kidneys is kind of close to zero. It just seems that every case, the danger is if you have impaired kidney function. MRI scans used a different contrast agent, iodine-based one, and there doesn't seem to be any risk at all. Yeah. The reason it's just a bit of concern is that you don't really want to be doing damage to your kidneys because it's irreversible. So that's just something to bear in mind if you're having kidney issues. Just remind everyone, look, it says, poor kidney function on my blood test. Do we really want to be doing this with contrast? But generally, they'll be far more aware of that than we are, so it should be fine. CT scans are good for showing like skeletal features. They're good for showing structures like between organs. They're good for showing changes of sizes in organs. So you might see, for example, lymph nodes that are swollen and therefore could be cancerous. So yeah, that's what CT scans are kind of useful for. The images aren't super clear. MRI scans are kind of much clearer images. But yeah, MRI scans are good for seeing like the difference between healthy and diseased tissue. They are good for when you need a very accurate picture. So for planning surgery, for example. So if you're going to have liver surgery, you'll have a liver MRI shortly before the surgery. One issue with them is that it can be very difficult to tell the difference between cancer and excess liquids in the body. So yeah, that's one thing kind of against MRIs. An MRI is a magnetic scan, so it stands for magnetic resonance imaging. They used to be called NMRI, but the N stood for nuclear, and that freaked too many people out, so they dropped the N. It's still the same scan. But the key point is that despite the N in NMRI, MRIs are magnetic scans. There is no radiation, not like a CT where it's using X-rays. Now, CT scans, the radiation dose is very, very low. As far as I can tell, it shouldn't have any consequences for adults. With kids, it's a very different thing. Just like the same with like a normal X-ray. Modern X-rays are digital, very, very low radiation. When I was a kid, X-rays used quite a bit of radiation, and has said like you should only have one a year. So MRIs are the very, very noisy scan. I don't know why, but the machine is ridiculously noisy. That can be quite unpleasant, especially the first time. I've had lots of MRI scans, lots and lots and lots of CT scans, and quite a few PET scans as well. MRI, the machine is like less claustrophobic. For MRI, you can ask for an open machine. Some hospitals have like an open machine, which is like not enclosed. I don't believe there are such things as open CT machines. There may be. But yeah, if you are the kind of person that panics when you're told to lie in a tunnel with a big noisy machine around you, it can be worth asking if there's any alternative. And potentially, I guess one alternative, if you're looking at a specific part of the body, would be ultrasound. So, for example, you can have ultrasound liver, and with that, you're lying on a bed, and a medical technician does an ultrasound scan with a handheld device. So that may be an option. So if that's an issue for you, it's worth asking. Don't just think nothing can be done. So then PET scans. The PET scan, the positron emission tomography scan, that's the one where you're injected with a radioactive sugar called FDG, and it goes on your body, takes like an hour. So when you do a PET scan, you have to lie in a darkened room for an hour generally. Here in Japan, you're not allowed to read, you're not allowed to listen to anything. You just lie down. The reason they don't want you reading is because your eyes are moving around, and then the FDG would start to pull up in your eyes. PET scan shows like the activity of tissue and organs. So if there's cancer, the FDG should build up in that area while you're lying down for an hour waiting for your scan. If certain organs are like working too much or whatever, they will glow on the PET scan. Typically a PET scan is PET CT, which means just the machine has a CT scanner built in. When you have a PET CT, you can't have the contrast agent, and that's just because there would be too much contrast when the images are fused together. So with PET CT, you get 3 images. You get the PET image, which is like the one with the colors on, with like glowing for tumors and things. You get the CT image, and then you get the fused image. They don't put any contrast in because the image would be like an overexposed photo. So those are like the main scans, and then there's also ultrasound, which it can be really helpful if you get like ultrasound done by a surgeon, because they're really, really good at it. So I should say that for whole body scans, like as a cancer patient, you'll often be having a CT scan every 3 months. Hopefully after some treatment, your oncologist says, good news, we're going to do the next scan in 4 months, and then later 6 months, and then hopefully once a year. But those whole body scans, the radiographers are very good at finding cancers and changes in whole body scans. But it does seem that for like a scan of an organ, or analyzing the bit of a whole body scan in an organ, a surgeon who specializes in that area can sometimes see things that a radiographer might miss because they have better knowledge of local anatomy. I guess I should say that like scans don't really show cancer. Scans show things or possibilities of things, and are very, very, very open to interpretation. And the probability of something being a tumor or not, or being tumor growth or not, is very open to interpretation. So in my case, for example, because I have stage 4 cancer, I guess the burden of evidence, like the threshold for evidence, is quite a bit lower. You know, if something appears, you can say, oh, it's probably cancer. But just as an example, 50% of scans of lungs have some kind of nodules on, and the majority of those wouldn't be cancer. So you can get things called granulomas in your lung, where like a little bit of grit has got into the lung and some tissues built up around that. So scans are very open to interpretation. Maybe that will change soon, because of course now we're just on the verge of getting the scans looked at by artificial intelligence systems instead of radiographers, or artificial intelligence systems plus radiographers. So maybe it's changing, but it's not an exact science at all. So one thing to bear in mind is, like, you hear people saying things like, oh, I can't believe the radiographer missed this new tumor, or something like that. And it's very understandable to feel like that, but that's not the reality of how scanning works. Scans may or may not show changes and things. So when I had a 75mm tumor appear over my liver, it was found in a PET CT scan, but it didn't show up on the PET part of it. Now, PET scans can usually show things of around 8mm, and this is 75mm, but the density was lower than the glowing bit of the PET scan would see. But because it was a PET CT scan, it showed up on the CT scan part of it. And then briefly, like genetic testing and liquid biopsies. Liquid biopsies are blood tests, kind of very advanced blood tests, looking at things like circulating tumor cells. So those are cells from the tumors that are swimming around in our blood. Looking at maybe free DNA, again, like DNA material, and some liquid biopsies, the analysis includes the full genome of the cancer, which means they're doing a full genetic analysis of the cancer, looking hopefully for mutations that are actionable, which means that there's some drug that is good for targeting that mutation, maybe a drug commonly used for another cancer type that may be worth trying. The circulating tumor cell tests or free DNA tests, they're potentially useful for warning you if you have no visible tumors and the tumor markers are stable, but you find circulating tumor cells. That may be a good indication that you should have some another scan soon or something like that. So these advanced testing, the most famous liquid biopsies are the IMPACT liquid biopsy, which is from Memorial Sloan Kettering in the US, and also Foundation One. It's another famous liquid biopsy. You can generally have them in any countries. If you might find a local place that does testing, or for example, when I had liquid biopsy a few years ago in Japan, it was sent to the US for analysis. I had the MSK Impact One, and it found 3 mutations, one of which had no drug associated, one of which had a clinical trial that I was recommended against because it was too toxic. And the third one, it was a clinical trial, but I couldn't join because I'd had one of the drugs, of the combination of drugs that was in the trial. And then the new tests that just becoming available now, things like microRNA testing and the N-nose test. These are really, at least at the moment, are for cancer screening. very, very sensitive test for cancer screening. So with microRNA, it's looking for little bits of non-functioning RNA. So as we remember from school, RNA kind of does the work of DNA. Is one of its roles, right? It goes out and does things. So RNA is like DNA, but instead of 2 strands, it's 1 strand. And this really developed as a screening test, and it's like screening from a drop of blood. So it's like pinprick, and then it can screen for hundreds of cancers. But potentially they're of use if you've got to the stage of no evidence of disease and you're wondering what you should do. Should you continue chemo for a while? Obviously, to keep an eye on things. So yeah, might be useful in that case. The N-nose test is one that uses a worm or a bunch of worms. So it uses nematode worms, which like the type that you often have in as like parasites in your intestines, and they're very averse to cancer. So they will move away from cancer. So you have a sample taken, put on a slide, and a bunch of worms, put it there, and specialists will look and decide, are the worms kind of slithering away from the sample enough to suggest that it's cancerous? But those are, yeah, maybe 100 times more accurate than tumor markers, is the figure that I've heard. So that's really been an overview of staging and grading and blood tests and the different scans and some of the advanced testing. And soon the handout will appear on the website makecancerhistory.jp. So yeah, please check it out.